Board Bombs.
Welcome back to Board Bombs. As I adjust my mic as we start, that's why I'm so excited to be here. Thank you to Marlena Wasiski-Kuhn, Doctor, for joining us again. If you're watching on the YouTubes, you can see our smiling faces. I have nice jet black with a satin finish headphones. Dr. Wasiski-Kuhn has pink and white headphones.
Yeah.
Very slick.
Smooth.
Very smooth. Glossy finish. Anyway, and I have my Board Bombs labeled microphone. We both have matching microphones, though. If Dr. Hussein were here, he would throw shade on the fact he does not have an expensive microphone like ours, because he always tries to act like a martyr. You know Dr. Hussein. He's not here right now. We don't know what he's doing.
It's probably at the Met Gala.
Yeah, we were just talking about that. Dr. Wasiski-Kuhn did a complete rundown of everything going on with Twitter. I really appreciate the news update. You know, there's different news outlets out there that will give you the daily briefing. Essentially, I just got that from Dr. Wasiski-Kuhn. I feel a lot more well-rounded and up-to-date on the news of the world. Yeah, connected. The news as in the Met Gala, the Kentucky Derby, and horrible storms that are going on. Well wishes, thoughts and prayers to people in the tornado alley of the United States as well.
Yeah, really.
Yeah, really. Anyway, let us dive into this. Again, we're Ian Board Moms. Dr. Hussein hates doing this, but I like mentioning who we are. He's like, if you don't know who we are, then you shouldn't listen to this podcast. But we're Ian Board Moms. And
if you happen to stumble upon us, we're here.
Yeah,
we're a podcast.
We're happy to be here.
Emergency medicine.
Exactly. But this is the fun, quick review of emergency medicine. This is like you're talking to someone on shift, and they're talking a mile a minute and giving you the rundown of something you have to know. This is not the let's talk about the pathophys emergency medicine. So if you don't like that, stick around and listen and see if you like us, but you may want to get your information from somewhere else. Otherwise, we're here, and we're great. Shout out to our only sponsor, EM News. You can go to emnews.com, the only sponsor we let sponsor us, hence being the only sponsor. Free publications. If you're an emergency medicine clinician, you get free access to all their stuff online. They have print media as well. It's great. Check it out. We love them. They're awesome to work with.
Yeah.
Love their content. Really thought-provoking articles.
It is. Variety.
Absolutely. Variety. Hey, you want to read the question? You want me to?
I'll read the question.
That's great.
All right. We're going to dive right in here. So, a 67-year-old female presents with abdominal pain, nausea, and vomiting. She is uncomfortable lying on the ED stretcher. She says that the pain that she has worsened this morning. She was watching the Kentucky Derby when Mystic Dan beat Sierra Leone by a nose. That's Mystic with a K. Mm-hmm. This prompted her to then watch Magic Mike and eat a pint of Cherry Garcia ice cream.
What else are you going to do?
So good. In doing so, she then developed abdominal pain, and it hasn't gone away, and then it just got worse this morning. On exam, she's got tenderness to her umbilicus, and has this area of erythema overlying it with swelling and bruising surrounding a firm, swollen region. You push on that, and it causes her exquisite pain, and she screams. She asks you if she feels bad because the ice cream had dairy and gluten in it. Which of the following is the next step? A, attempt bedside reduction. B, CT abdomen pelvis with IV contrast. C, consult general surgery. Or D, IV piptazo.
Correct answer here, I believe, is going to be choice B, CT abdomen pelvis. Keyword, IV contrast.
IV contrast, absolutely.
IV contrast.
Here.
If you're doing PO contrast, we would still be waiting for it right now.
Don't do that, God.
Hey, we're talking about, hernias here, obviously, and umbilicus. Depends if you're from Canada or not, I think.
I got you thinking about it.
Exactly. I'm thinking. Trying to depend how many Canadians I've worked with, they pronounce it differently. This is a case, obviously, of an incarcerated and strangulated hernia. And what points to that is going to be the skin changes as well as her exam. And we're going to tell you the rundown here of essentially reducible hernias, incarcerated hernias, and strangulated hernias. Those are the three things we're covering today. This is not at all, hence why we are the blue-collar podcast, as Dr. Hussein says. this is not a review of all the hernia types. The
No.
things that you got pimped on as a medical student. If you're still a medical student, we're sorry. Get ready for surgery rotation. I remember like my second days as a medical student, I walked in and it was a mesh hernia repair case, like standard mesh hernia. And like the surgeon, I didn't know, no one prepped me. I was like such a naive med student. No one prepped me that like surgeons just like randomly ask you these things. I thought like no one's going to pay attention to me. Why would the surgeon even bother talking to me? Like, I thought I was just going to stand there and watch. And this, of course, I get the one surgeon who like trained at Mayo and he's like ready to go. He is ready to quiz and he's asking me literally everything. I still remember this as a med student, asking me all these things like spaghetti hernias and like all these different hernia types, how they happen, all this. And I'm not making fun of the guy. I appreciate him teaching. But it was like
a ton of knowledge.
Yeah, it was a ton of knowledge, but it was teaching in a way I was like, holy crap, I know nothing. I was like, well, I don't know the answer to that. And he's like, we'll look it up and get with me afterward. I'm like, yes, sir. Anyway.
So we're not going to do that.
So this is what we're not going to do. Yeah, exactly. So why don't you dive into what the most common hernias are, as in 2 of them?
Yeah, I mean.
And then the presentation.
This is great.
Before you do that, we have to talk about rapid board bombs.
Yeah.
Our one and
rapid
only.
bombs.
EM Rapid Bombs. The one and only Rapid Podcast. Give us a 30-second spiel about that.
Yeah, it's a very focused, quick,
Laser focus.
question bank podcast. Episodes are like 2 to 3 minutes. You get a couple of them a week. It's focused on a very specific portion of a topic, but it's always something that's going to be high yield that you're going to see on your boards, and it just helps you get spaced repetition, and you can work it into your daily routine so that you don't have to focus on finding time to study. We'll just do it for you.
Mm-hmm. We should have a new slogan for EM Rapid Bombs. It should be EM Rapid Bombs. Be street smart. Nice and simple. It's not just like nerd smart, it's like casual smart.
Yeah.
You know how to function in life. No one's going to care if you can quote the SIP inhibitors, but people do care if you can reduce a hernia.
It's true.
It's true.
So, back to hernias.
Back to hernias.
So, there was this retrospective review that looked at thousands of hernias, and guess what? 70% of them were inguinal hernias. So that's definitely what you're going to see most commonly. Yep. And then about 13% were umbilical hernias. And then there was a whole bunch of other different types that were less than that that you can look up if you feel like it, but we're not going to talk about them.
Nope.
You just need to know inguinal is by far the most common.
They exist.
Yeah.
Why don't you delve into the presentation here? It sounds like we're gonna focus more on inguinal, which is totally fine because those are by far the most common. So when we describe presentation, picture this as an umbilical as well, like our question stem, but we're gonna focus more on the inguinal aspect because that's just the most common type of hernia you're gonna see.
Absolutely. So these patients are typically going to complain of abdominal or scrotal pain. They may have superficial abdominal wall swelling, and it would worsen with any kind of maneuver that increases intra-abdominal pressure. So sometimes there's a preceding event involving heavy lifting or just trying to go to the bathroom, coughing, things like that. Symptoms like vomiting, constipation, and abdominal distension can raise concern for like a co-occurring small bowel obstruction. The exam, so swelling's going to be wherever the hernia is. So inguinal, umbilical, get fancy, have a ventral or femoral one. But
I think I remember answering that as to the surgeon when he asked. He's like, how do hernias present? I said, well, there's typically swelling where the hernia is.
See, you were already blue collar from day one.
I was ready to be an emergency doctor. No, I should have said the answer is CT.
They present
Where is the hernia?
CT.
Well, it depends if my CT can find it.
It's in the CT scanner. Oh, it's great. Okay, yeah. So oftentimes the swelling can be reduced with gentle pressure, and patients will actually sometimes just do this themselves. And so they'll come in telling you like, oh, I usually just push it back in. That's called a reducible hernia. If it cannot be reduced at bedside, that is an incarcerated hernia. And then if, like this patient in the question stem, there's tenderness to palpation with overlying skin changes like redness, purple, blue, then that's going to increase suspicion for a strangulated hernia.
Right. For sure. So, joking about CT, in all seriousness, the CT scan is your best test here. Of course, a physical exam can definitely diagnose a hernia and diagnose a hernia sac, but the CT is going to help you in terms of the strangulation and incarceration of a hernia. It's really interesting. I feel like those two terms are mixed up a lot at work. Either some nurses or other doctors will like throw those terms around a lot and say, oh, it's incarcerated or strangulated or both or one or the other. I always think of this sounds really silly, but what would be worse to you, being incarcerated or being strangulated?
Oh, God.
And so I always remember, well, maybe to some people, maybe one's worse than the other. Maybe they have an innate fear of going to jail. But to me, being strangled is a lot worse than being incarcerated, probably.
That's true.
So incarcerated is not as serious. So think about that. Strangulated is the surgical emergency, literally. Like there's, bowel that is literally being strangled, like it's dying off from its blood supply, versus incarcerated means it's trapped there and it's not reducible at the moment. So we'll get to some of those details in a minute, but those are the main like overview that Marlena covered. So when you get a CTM in pelvis, there's some key features that may be seen, and the CT may show this classic zone of transition where you see a change in the diameter of the small bowel or large bowel from dilated to normal or decreased diameter. And this is what's called a pinch point. It's literally as it enters that hernia sac, it's pinched into the hernia sac. And you'll see that. Yeah, thank you, Marlena. If you're watching on the YouTubes, you can see Marlena demonstrating a pinch point. Our resident radiologist here, clinically correlating. Lovely. Anyway, other signs that suggest strangulation, what you're going to see is engorged vessels. You're going to see a lot of fat stranding around that bowel wall, thickened bowel wall. Those are the key things, along with the skin findings. This is why it's so important to tell your radiologist things you're looking for. We've covered this before, I think on the Small Bowel podcast or other podcasts where we said, tell your radiologist what you're looking for. And that is so important. I was just teaching a physician about that today, a resident physician about that today, telling about, hey, we need to make sure on our indications of these studies that you are either putting your differential or putting where the pain is, or saying this patient has an umbilical hernia, it's red, it's swollen, I can't reduce it, can you evaluate for incarcerated hernia? That is so helpful to radiologists. And sometimes I hear people, I don't know if you hear this too, Marlena, but some people always push back or clap back, I guess, and they say, well, I don't want to lead them on or bias them. And I'm like, well, if someone hands you an EKG, what is your first question? What are they here for? It's like you always need a clinical correlation of some type to do. You can't just look at something randomly and say, oh, yeah, that's fine. So it's very important that you get that lead point and give that differential, give that presentation to the radiologist. They'll be very thankful for it.
Yep, totally true.
Cool. Hey, talk about reduction here. And I'll add in what I learned from my recent review of the surgery literature. Yeah,
so bedside reduction is indicated whenever a hernia is incarcerated, but there's not evidence of strangulation. Signs the suggestive of the strangulation we already talked about, like the skin changes, or if they're peritoneal, or if you get the CT scan, it says it's strangulated. Don't shove the dead bowel back in.
Not good.
So to prepare for reduction, you can make gravity your friend. So put the patient in supine and Trendelenburg position. You can put an ice pack overlying the area of swelling. I have had a funny story where I put an ice pack on a patient to try and reduce them. And then the surgeon came down and was like, oh my God, the skin changes. And I was like, oh, it's just, I had an ice pack sitting on it for the past 10 minutes. But so warn your surgeon if you're going to do that. But yeah, the ice pack can help reduce some of the swelling. Give them good pain control, because otherwise they're going to be fighting against you. You're making your own job harder. Procedural sedation can really help here too. Right. Or, just like a little bit of Versed helps everything. Muscle relaxation, it's going to increase your likelihood of success. And honestly, sometimes if you have good pain control and a little bit of sedation, it might spontaneously reduce once you've positioned the patient. Mm-hmm.
And you usually don't have to do procedural sedation, but yeah, you're right. Some type of onyxiolysis, as I like to say, to sound very educated. or other types of light sedating medications like a benzo or IV morphine or something, or fentanyl. That's going to be your best bet for sure. It's really interesting. I read a Surgery Journal article on this. I typed in reduction techniques in the Googles, and I found one article on PubMed, and you'll be shocked at how helpful their mnemonic is. It says, how to reduce a hernia. They came up with they literally published this. These people are getting promoted somewhere at some hospital. And I hope they're listening to this podcast and hope they write to us. Their very helpful mnemonic is GPS. What do you think the G stands for? Like, logical guess.
Gravity would have been my guess.
Well, no, it means gentle. Be gentle. It says be gentle. The P is going to be prepared. And the S is be safe.
Literally nothing about that is helpful.
Yeah, nothing helpful at all.
Unless you're like a kindergarten teacher leading a fire drill.
The be prepared part, all it mentions is like, have oxygen ready. I'm like, what is the oxygen going to do?
Put oxygen on the hernia.
Yeah, put the little prongs at the top of the hernia tip. Anyway, so silly. Okay, so all jokes aside, can you tell the audience and our dear listeners about actually how to reduce a hernia? Like the physical prospect. You already talked about the positioning and the pain meds.
Right. So you're going to want to find the outline of the defect that the hernia is coming out, like whatever abdominal wall defect that is. Do that with your non-dominant hand, and then use your dominant hand to put gentle inward pressure at the base. So like the most proximal portion of the hernia. And you're going to like slowly provide slow, firm, gentle pressure. Don't lift your hand up or you're going to undo all the work that you just put in. You want to take care to avoid completely collapsing the lumen of any small bowel at the pinch point, because that's just going to lead any remaining trap bowel to get distended. So, just slow, steady. And sometimes if it's a big defect, you may have to ask another person to come in and be a third or fourth hand, and that's totally fine. Absolutely, you should ask someone to do that.
Cool. Once you do that, let's say you are able to reduce it, what's the next step usually with these?
A reduced hernia that doesn't have any signs of bowel ischemia can just be sent home with appropriate follow-up for an elective repair. If you want to give them like an abdominal binder or something so that they're not worried that it'll happen again, that's fine.
Yeah, for sure. And you're always welcome to reach out to your surgeon and try to give them a rapid follow-up. But yeah, outpatient follow-up is the best case for these. And obviously ones that remain incarcerated, like you've given it your best shot, you're going to call a surgeon. Or, of course, strangulation, you should have already called them. One question I feel like I get a lot from residents is if I'm able to reduce that hernia at bedside, do I even need imaging? I would say it probably depends on two things. I don't think there's a clear answer to this, by the way. But one, how easy was it to reduce it? And two, do they have any pain afterward? Let's say you reduce it and they're like, oh, I feel better. Probably don't need a CT scan. It's probably not incarcerated or strangulated if you just successfully did all that just fine. But if you're having trouble completely reducing it, or it keeps popping back out and it's very painful, then that's obviously an indication for imaging. There's no clear answer on this, and the boards are never going to ask you that. But just a real-life pearl tip here. Yeah, that sounds reasonable? Is that what you do in your shop?
Yeah, definitely.
Cool. Let's play a game here about different hernias. I'm going to ask you different questions about hernias. I want you to answer them. Sound good?
Sounds good.
Don't worry, it won't be about spaghetti. I didn't train.
I was going to say, don't ask me about words I don't know.
I didn't train
Dr.
at Mayo,
Briggs.
so they won't be hard questions. I work in Tennessee. They will be easy questions. There'll probably be spelling errors too. So, all right, what are the different statuses that hernias can have? We've covered this already. Let's just summarize. What are the three different classifications here? Summarize them all. 1,
reducible.
Okay.
That's when it's soft and easy to put back through the defect.
Awesome.
Usually not that painful, but you just push it right back in. 2, incarcerated. That's when it feels hard. It's tender to palpation. You can't get it back in at first. And then 3, strangulated. Remember, strangling is worse than incarceration.
Yes, always.
And that's when an incarcerated piece of bowel becomes cut off from a blood supply, and now you have dying bowel. That's going to be exquisitely painful. The patients look bad. Their skin changes overlying the hernia site usually, and the patients act like those with a bowel obstruction, and that is a surgical emergency.
Awesome. Yeah, when I think of a strangulated and incarcerated bowel, I'm thinking of like a prison fight of some type.
It's bad.
It's bad. It's all bad. Hey,
Call
so
a friend.
this next one, we're going to talk about what are the treatment options for these hernias. Why don't we make this a social? I'm going to introduce you. It's like a volleyball volley. I'm just going to set, and you're going to spike the ball. So you're going to spike the ball and do a social post here. So look at the camera and tell us here, what are the treatment options for these hernia types? So starting with reducible and going from there.
Reducible. Reduce the hernia. It should be easily reducible.
Sweet. Incarcerated.
Make an attempt to reduce the hernia. Provide adequate pain control.
We talked about cold packs, Trendelenburg. Yes.
Firm, steady pressure.
Yes. Don't apply oxygen to the hernia site.
Probably won't help. GPS.
And if you are unable to do so after a really good attempt,
Call surgery.
call your friendly neighborhood surgeon. If you're successful, you could observe them for a short time. You can probably just send them home after a very short period of observation.
Mm-hmm.
Great. Strangulated. What's your game plan?
Do not attempt reduction.
No.
Stop
what you're doing. And you're going to consult immediately. Yeah.
Yep. You're just going to make a call. Let someone else take control.
Let someone else take care of it. Let someone else take the risk. All right. Let's do a summary here. So the most important step you're doing here is determining if an incarcerated hernia is strangulated. And strangulation means bowel necrosis, obviously. I know we've emphasized that a lot, but you'd be shocked the number of people who don't know the difference between these two, and it's so important to understand that. Hernias that are clearly strangulated should never be reduced at all, and you're calling surgery immediately. But these aren't always distinguished. Now, physical exam is usually pretty helpful here, but another indication is, okay, you've tried pushing a little bit, didn't work, go to CT then. Don't keep pushing. If you're not getting it, you need a CT scan, especially if they're in a lot of pain. There's a good chance it could be strangulated or showing signs of strangulation. So that's very important that you do that. What about systemic signs? Not always present, usually not going to have a fever. The only time they're going to have vomiting is if there's an obstruction associated with that, bowel obstruction. But toxic appearance of patients obviously would warrant a CT scan before anything, before you just go in there poking around hernias. Probably not a good idea. Always make sure it's not a AAA before you go poking on it too.
Oh gosh.
So,
yeah.
Whoopsie.
If it's pulsating,
If it's
don't push it.
hernias should not pulsate.
No.
Last thing here, some of you probably been listening and saying, "What about the lactate? What about a lactic acid?" Don't do that. So lactates are often sent in cases of incarcerated hernia. They've done studies on this. Just by the fact of a lactate being normal, it has limited sensitivity and specificity. And just by a lactate being normal does not mean that strangulation is ruled out. So just understand that. Even if you get pushed back on the phone from a surgeon who says, well, I don't care what the CT says, the lactate's negative, don't listen to that person. Try your best to advocate for the patient. A normal lactate does not rule out strangulation if there's CT findings and or skin findings concerning strangulation. And I really think that is it. What other key points do you have? Anything?
No, just I hope that Iltifat's having a really good time at the Met Gala.
At the Met Gala, yes. I can only imagine what type of outfit he would wear.
He might dress up as a bush, like a shrubbery.
Shrubbery to sneak into the Met Gala.
Yeah.
Yeah, he would do it.
I bet he owns a tuxedo.
Oh, yeah. He absolutely owns a tuxedo. But his wife picked it out for him. All right. Let's end today's show. It's been a pleasure. Marlena, always a pleasure to have you. And we got some exciting things Marlena and I were talking about for this summer. We're really excited. Some exciting changes coming to EM board bombs. We're offering some new things. I know you're already excited. You're like, how could they offer more? They do so much already. And we're like, well, we do it for the people. We do it for our blue-collar podcast listeners. Anyway, thanks for joining us. We'll see you next time.